57-year-old male patient presented with long-standing hypertension and on polymedicine for many years, but uncontrolled hypertension despite multiple medicines and high dosages of antihypertensive medications. These patients need to rule out a secondary cause of hypertension. Also, one has to look for any end organ damage due to hypertension. This is the left coronary artery. It just shows there's a plaque in the mid-distal segment of the LAD. Initially it looked like a muscle bridge, but in the aleocranial view, if you look at it, there is a non-significant plaque in the mid-distal segment. This is the aleocaudal view to look at the coronary, and this is a right coronary artery which shows a small plaque in the mid-segment of the right coronary artery. It's a dominant right coronary artery and with a non-significant plaque in the mid-segment. This is to look at the gradient between the aorta to look any coarctation, but you can notice that there is a aortic knuckle calcification, again may be related to both hypertension and diabetes, and this is a pullback gradient which appears to be normal. This was also to look for any renal artery stenosis due to hypertension and to look for any mass which can be a adrenal mass due to pheochromocytoma, which is a secondary cause of hypertension. The left renal artery appears to be normal, the right renal artery also appears to be normal. An LV angiogram is made in this patient basically to look for LV hypertrophy, to look for cardiomyopathy, and to look for the LV and diastolic pressures and any wall motion abnormality due to end-stage heart disease due to long-standing severe hypertension on polymedicine. Here you can see that the LV contractility is normal, the LV and diastolic pressure was 15. On 2D echo, there was a diastolic dysfunction suggestive of long-standing hypertension in this patient. Angiogram was made in the peripheral arteries. So this was angiogram of the peripheral arteries to show the common femoral, the iliac, the SFA, the popliteal, and the trifurcation. And it did show that there was a sluggish flow in the tibial and the distal peroneal arteries. This could be due to endothelial dysfunction due to hypertension and diabetes. And this is a DSA of the trifurcation. This is the left side leg, again showing the trifurcation, the tibial and the peroneal with a sluggish distal flow. Again probably due to endothelial dysfunction due to long-standing hypertension and diabetes. With informed consent, this is a tortuous iliac artery, as you can see, again may be related to hypertension. With informed consent, I also look at the carotid arteries to see for any carotid plaque or the intima medial thickness, and here you can see the right-sided carotid artery, common carotid dividing into internal carotid and external carotid, and you can see a small plaque in the right-sided internal carotid artery with a little dilatation. And this is the left-sided carotid artery. Again it is showing a non-significant plaque in the internal carotid artery at a bend, but the intracerebral vessels appear to be okay. The carotids were looked at with informed consent. So basically in a long-standing hypertension on polymedicine which is uncontrolled, what is important is basically to look for any secondary causes of hypertension, and also to find out if there is any end organ damage including carotid disease, renal artery stenosis, coarctation of aorta, pheochromocytoma, and to look at renal artery stenosis and peripheral vascular disease, and also to do a fundoscopy to look at the retina for any retinopathy in a long-standing hypertension on polymedicine which is uncontrolled. Thank you.